Well, thank you, everybody. I am thrilled to introduce Dr. Keila Lopez, who is an associate professor of pediatrics in the section of pediatric cardiology at Texas Children's Hospital and Baylor College of Medicine, as well as an adjunct assistant professor in the Department of Sociology at Rice University and co-investigator for the Texas Children's Policy and Advocacy Center. So you can tell she has quite a resume. She completed medical school at Rush Medical College in Chicago and then completed residency in pediatrics at the University of Chicago, where she's from. She subsequently completed the Commonwealth Fund Fellowship at Harvard School of Public Health in Minority Health Policy and Healthcare Management in Boston, Massachusetts, and then completed her medical training with a fellowship in imaging at Baylor College of Medicine, Texas Children's Hospital, where she's now on faculty. So I think Dr. Lopez's research portfolio is truly impressive and reflects a longstanding commitment to addressing health disparities and public health initiatives. She's presented nationally on health disparities, leading teams to conduct multidisciplinary work using large databases and GIS mapping to better understand the connection between health, socioeconomic status, neighborhood-level factors, and access to quality health care. And she's participated in several community initiatives to help underserved populations. And most recently was the only Latina and the pediatrician appointed to the Houston Mayor's COVID-19 Health Equity Response Task Force. So I think given her public health and health policy background, she has a lot to say to us in terms of her first talk today, and I really look forward to hearing you speak. Thank you so much for coming.
I don't know if everyone here knows Paul. He is a whiz. This is the first time I've ever been on WebEx with notes pages. So I think he deserves a round of applause. All right, well, thank you so much for the opportunity to be here. I'm thrilled to be here. It is stunningly beautiful. As we've been driving around, I knew that about this place, but you don't really know until you see it. So thank you so much for the invitation. My talk today is entitled Good Trouble, the pursuit of health equity in the subspecialty care space. I have no disclosures. So what is good trouble? So good trouble is when you see something that is not right, that is not fair, and that is not just, don't lose hope, say something, do something, shake things up. And those are the words of Congressman John Lewis, who was best known as a civil rights movement pioneer. He was one of the big six civil rights leaders alongside Dr. Martin Luther King, and one of the organizers behind the 1963 March on Washington, which is, of course, was the same rally that Dr. King spoke and gave the I Have a Dream speech. He was elected to Congress in 1986, and he served until, starting from January 1987 until he died somewhat recently, as the representative for Georgia's 5th District. And he was an orator, unlike many others, and his words really galvanized action for multiple generations. And so I use the inspiration of his words to inform some of the policies that I use moving forward in terms of applying them to pediatric principles into the pediatric space when thinking about how to change outcomes for pediatric chronic disease populations. So we're going to use some of his words, or talk about some of his words now. So one of his quotes is, "Freedom is the continuous action we all must take, and each generation must do its part to create an even more fair, more just society." And from that I took that we need to understand where we started in medicine to target where we are going and to know what is possible moving forward. Next quote, "When you see something that is not right, not just, and not fair, you have a moral obligation to say something, to do something. And our children and their children will ask us, what did you do? What did you say?" And from this I take, kids are natural risk takers. They are people who question, and they often will voice injustices. And we should follow their lead to make bigger impacts on behalf of those populations. Next quote, "Never let anyone, any person, or any force dampen, dim, or diminish your light. Study the path of others to make your way easier and more abundant." And from this I took we should embrace collaboration, innovation, and interventions to advance health equity, even in the subspecialty space in pediatrics. Finally, We will stand up for what is right, what is fair, and what is just. Healthcare is a right and not a privilege. And from that I take, we need more voices to translate research, education, and QI into effective policy in pediatrics. So given these words, we're going to use some of these words to kind of inform what we'll be talking about today and the inspiration for today's talk. So we'll be talking about applying good trouble principles to this pediatric subspecialty care space, understanding upstream forces that result in downstream health inequities, illustrating work by subspecialty pediatric equity leaders, describing health equity research in subspecialty pediatrics to impact pediatric chronic disease populations, and translating your voice into health policies to reduce pediatric health inequities. So first, there was a question and an answer that honestly changed the trajectory of my career. I was in public health school at the time. I had finished pediatrics training, and I remember being very confused about why it was that anyone would vote for a policy that could potentially harm children. It just made no sense to me. I thought, well, why would you want to do that? And so I asked this question in my public policy class, and the answer shook me to my core because it was not something that I expected to hear, and it was frankly not something that I had ever really considered. And the answer was, well, children can't vote. And because of that, we have to think about what it means when policies are either rejected or adopted for children. So pediatricians are actually the voice of children for policymakers. So we are the ones that need to give a little bit of good trouble in this space to advocate for these populations. So the awareness that we have about their chronic disease or acute diseases, the data that we can generate in the various institutions that we serve, and then a little bit of good trouble can result in things like increased focus on public health, increased research funding for interventions, not just for describing the problem, but for interventions, and health policy changes, ultimately at the state, federal levels. And pediatricians have defined good trouble for a very long time. General pediatricians in particular have done this apparently at the American Academy of Pediatrics, and that's been something that's been going on forever. So this is a statement on pediatricians and public health, optimizing the health and well-being of the nation's children. So these are some of the statements that they put out. The AAP also put out a statement on opposing separation of children and their parents at the border, given the mental health issues. They further want to declare a national emergency in child and adolescent mental health, and this is, of course, as a result of the COVID-19 pandemic. And then more recently, they've given a statement on the impact of racism on child and adolescent health. And so a lot of what pediatricians do actually defines good trouble. But therein lies the disconnect. And so I was taught, and I think a lot of people in my generation and beyond were taught, that if you're going to be doing public health and advocacy and any health equity pursuits, that's a general pediatrician's job. That's Gen Ped. So they talk about things like safe water, and they talk about things like vaccines, and that's their problem, but I'm a subspecialist, so that's not really my issue. And that's where the opportunity lies. And so really, we are here to be the voice of the least of these, low-income children with chronic diseases who need more voices. And so pediatric subspecialists are actually ideal good trouble partners. And so if we can take some of the data that we generate and the advocacy that we can provide, these are the things that together with the general pediatricians can drive policy, again, at the local, state, and federal levels. So let's talk a little bit about the upstream forces that result in some of these downstream health inequities that we see. I'm sure people are familiar with this graphic. You'll note that in the background there is soccer being played, and it's not the traditional baseball that you see with this graphic. And I just want to take this time to give a public service announcement. The World Cup starts on Sunday, November 20th. So for those of you who don't know, it is a very important event that occurs every 4 years. But, so let's talk about some terms first. So equality, equity, and justice. Equality assumes that everyone benefits from the same supports. And you can see here that everyone is given a box to stand on to see this game, and that really only the two people on the left can see the game, but the person in the white t-shirt cannot see the game despite being given the same support as the other two individuals. In the second image, you can see that individuals are given different supports to make it possible for all of them to have equal access to the game. They're being treated equitably. In the third panel there, you can see that this is where the game can be seen without any supports or accommodations because the cause of the inequity has been addressed, or the barrier to the game is no longer. And so the question is, what in the world are some of the things that create some of those systemic barriers? So this is the time where we have some audience participation. Can you guys tell me any major contributors to health outcomes? And for those of you who are quick readers, you might have seen that next slide. But anything that contributes to health equity inequities. You can shut them out, other than what your one-on-one relationship with your doctor in the office. So insurance is an issue. Transportation. Food insecurity. Ability to pay for your doctor's visit. So health literacy. And so you guys are all naming the social determinants of health, right? And so there's actually other contributors to inequitable health outcomes, and we're going to talk about those today. So the political and structural determinants of health, the social determinants of health, which many of you brought up, the digital and health literacy, which again can be a part of the social determinants of health, as well as data dissemination. And so let's talk about stepping back and to understand really how some of these upstream causes end up resulting in downstream health inequities. First, let's talk about the political determinants of health. The political determinants of health have to do with the interaction between the government, commercial interests, technology, the economy, and the distribution of resources, which lead directly into state and federal health policies. These in turn can impact the structural determinants of health and the social determinants of health, which can either move us towards a more equitable or a more inequitable health outcome. Systemic or structural determinants of health are rooted in key institutions and processes from socioeconomic and political contexts, and these encompass a broad set of policies, economic systems, and social hierarchies that can affect individuals at various levels. So the structural determinants of health make an impact at the state, federal, and local level, as well as the institutional level, and in the United States, in many ways, has generated and maintained unequal social hierarchies, which created social determinants of health that were unequal, which then resulted in health disparities. The social determinants of health we were all discussing earlier, right? So these are the conditions in which people are born, grow, work, live, age, in a wider set of forces that shape their daily conditions of their daily life. And so the social determinants of health put people at risk for poor health outcomes. So things like living in an area that is a food desert, that you don't have access to a pharmacy, that you don't have access to a compounding pharmacy, that you have a highly polluted area. So those kids are often getting asthma attacks and coming to the emergency room often. So those are some examples. Health literacy is important as well. And so health literacy, or personal health literacy, is the degree to which individuals have the ability to find, understand, and use information and services to inform health-related decisions and actions for themselves and others. And so you can imagine this would be more challenging if English is your second language. Organizational health literacy is the degree to which organizations equitably enable individuals to find, understand, and use information and services to inform health-related decisions. And it turns out that organizational health literacy is almost as important as personal health literacy. But we also have to remember digital literacies. So digital literacies has actually been called the super social determinant of health because they actually address all of the other social determinants of health. So for example, applications for employment, for housing, for Medicaid, and increasingly for someone's health care, in general, things like patient portals, are increasingly and sometimes exclusively available online. So there's a greater reliance on these digital tools and the potential of who has the ability to access these tools, and the disparities of those who can and cannot do that result in of course, exacerbating health disparities. I can tell you I had a patient in clinic who I asked them if they had signed up for MyChart to be able to get their COVID vaccine for their child. MyChart is our patient portal. And they said, well, what's that? And I explained. And so I said, you just sign up for it online. And they said, oh, well, she can help us when we get home. And they pointed to their 7-year-old because she knew more about, well, frankly, she spoke English, and she also knew more about how to do electronic stuff than her parents. And so this is a very real issue. Finally, collaboration with communities, data exchange, and dissemination of this data is critically important. Participation requires reciprocation, particularly for communities that are underrepresented in medicine, and that reciprocation comes in the form of involving communities in research design, in who is participating in that research and running that research, and in disseminating that research, and the timeliness of that dissemination. So let's turn our focus to systemic determinants of health and inequities just for a moment to see where they really stem from. So this is thing number one that I want you to take away from this presentation, is that systemic inequities stem from racism. There's no two ways about it. And so there are at least 4 different forms of racism. There is structural, institutional, interpersonal, and internalized. And for the purposes of this talk, I'm going to be focusing on the first two, but suffice it to say that the other two are also very important. So let's start off with structural or systemic inequities. So these are often synonymous with structural racism, and it is a silent opportunity killer. It is the blind interaction between institutions, policies, and practices that inevitably perpetuates barriers to opportunities and racial disparities. Institutional racism occurs within institutions and systems of power, and this refers to unfair policies and discriminatory practices of particular institutions in places like hospitals, schools, etc., that routinely produce racially inequitable outcomes for people of color. So there are two notable examples of this here in Portland, or in Oregon. So in the 1950s, Congress passed the Oregon Donation Land Act, and this is the federal law that stripped tribes of their land, giving it to whites who stepped foot in the region less than a generation earlier. And these settlers claimed 2.5 million acres of tribal land, including sites that formerly became Portland a year later. In 1844, the government of the territory simultaneously banned slavery and required that all African Americans must leave the area, and in fact, later the state. And then only 5 years later, in 1849, there was another law that made it illegal for African Americans to even enter Oregon, even if you're just coming to visit. And that was not just for coming to stay. So Oregon was actually built on exclusion with legislation in place in its statehood in 1859 that made it illegal for Black Americans to visit, own property, or even to live in the state, and that was stayed in place until Civil War amendments to the U.S. Constitution occurred. And so that's one major example. And the other one is the United States Congress Homeowners Loan Corporation. So this is something that happened in 1933 because of the foreclosures of the Great Depression. Individuals were having a hard time owning land and owning houses, and so these low interest mortgages for homeowners and for private mortgage lenders were what the government decided were going to be helpful during the Great Depression. So in the early 30s, the agency served about 1 million households, and the outcome of this program was the creation of these infamous residential security maps that categorize cities into neighborhoods according to 4 different grades. And of course, this is the map of Portland. So the grade A neighborhoods there are the ones that are in green. These are the best neighborhoods. They were considered ethnically homogeneous, and they had room to be further developed. Grade D neighborhoods were considered hazardous, and they are the ones that are colored in red. And these neighborhoods had low ownership rates, older housing, and they had individuals that lived there that were thought to be or considered to be undesirable populations, which the Portland Realty Board adopted a rule declaring it unethical for an agent to sell property to Blacks and Chinese people in these green neighborhoods. So this language was not removed until 1956. And these maps kicked off systemic mortgage discrimination in America's neighborhoods. This is a practice later known as redlining, which I'm sure you've all heard of. And it resulted in more people of color living in areas that got less other types of funding, including schools, grocery stores, hospitals, quality hospitals, etc. So it turns out that that your zip code matters more than your genetic code. So thing number 2 to take away from this, I'm going to say that again. Your zip code matters more than your genetic code. And so we're going to zero in on a distilled down version of the erosion of the Portland red line map here. And I'd like you to pay attention to this area that is circled in red. Okay, so that's one of the red line districts in Portland. And let's see how it compares to where do we find poverty in Portland. Well, you can see that the darkest colors there are the areas that are the most impoverished. It's the exact same area that it was redlined back in the 30s. Well, how does it compare to the percent of houses that are rented and not owned? This is another map that demonstrates that the darkest colors are homes that are rented and not owned. Once again, same redlined area. And then what about who lives in this area? What percentage of individuals live in this area? And I know that Portland is not the most diverse city that I've ever visited. However, of the people that live in this area, the highest percentage of African Americans are the ones that live in the same exact area. Okay, this is not a coincidence. This was built into the system, and there is a reason that these outcomes are the way they look, because it was designed to be this way. So any guesses on the life expectancy in Oregon? I'm going to throw out some life expectancy ages in Oregon. Average life expectancy in Oregon. Anybody? 76. Other guesses? 85. Wow, that is, wow, I'm going to hang out with that person. Okay. So the average life expectancy in Oregon is 79.9. But of course, your zip code plays a major factor as to whether you are above or below that number, okay? So in Oregon, there are certain counties where the life expectancy is as high as 89.1, so whoever it was that said that might live in that county. But there's other ones that the life expectancy is as low as 66.2. All right, this is all within the state of Oregon. So that is a difference of 23 years. And that's, again, your life expectancy is a direct result of where you live. And so this tracks heavily, of course, with areas where Blacks and Latinos live for the same red line reasons that we discussed, right? And so any guesses on the city in America that has the highest life expectancy gap across the board? Throw out some guesses. Big cities, anybody? New York? Boston, Chicago? Detroit. That's a great guess. Detroit is a good guess. There's a lot of disparities happening there. Houston. Oh, thank you. So the number one life expectancy gap in the United States is, in fact, my hometown of Chicago. If you live on the south side versus living on the north side, the life expectancy gap is upwards of 30 years, just based on where you live.
He ran off, got the record. And
I don't know, he's participating.
her knee.
If you could mute yourself, please.
Oh, sure.
So
Could you find the mute button? Thanks.
Oh, I love, there's something I like that. I really thought that Zoom was, that the webinar was participating.
I can bring her next Friday.
All right, we're trying to find the speaker who needs to mute themselves, but maybe you can help me by doing it yourself.
All right.
And we could just have her do a tech appointment.
So you can see that Chicago is not the only place that has a high life expectancy gap. Neither is Oregon. You can see that all these various cities have high life expectancy gaps. And so it's important to understand that these life expectancy gaps, we're talking about full life, but that of course starts in childhood, right? So the beginnings of these gaps starts in childhood. And so in Houston, so we talk about Houston for a minute, in Houston, if you're a child living in the 5th Ward in Houston, which was another one of those red line districts, your likelihood of having cancer, of having leukemia, is 5 times higher than it is anywhere else in the city. Not 5%, but 5 times higher, okay? And that is, again, the same red line practice that we were talking about. And so 5th Ward residents were actually recently, in September of this year, notified of toxic chemicals found in their soil samples. Again, this is not a coincidence. It was designed this way, all right? So let's take all of these things together. This is a schematic that puts it all together, so let's kind of group in what we've learned. So we talked about how the political determinants of health then are things that inform the structural determinants of health, which then in turn inform the social determinants of health. And if you have that interacting with a chronic disease like congenital heart disease, right, or congenital heart disease severity in our case, you add in things like digital health literacy, as well as data dissemination. So, sometimes you don't know what you don't know. A lot of people aren't savvy enough to do the research that's required. Then all of those things end up resulting in impacting health inequities. So it's not just the social determinants of health, okay? There's a reason that the social determinants of health are unequal, and that's all of what we discussed today. Any other guesses on one major player that impacted health equity and well-being in 2022? Or actually starting in 2020, for that matter. That's a really big hint. What is that? Inability to isolate, okay. Any other guesses in the major contributor to some of the health inequities from 2020 on? So the answer is misinformation and disinformation, okay? So a lot of this exists out there, right? And it has really impacted our ability to deliver healthcare. And it's not a coincidence of who is being targeted for this misinformation and disinformation. I can tell you that the community that adopts the highest amount of disinformation are Latinos. 53% of Latinos get their information directly from social media sources. And so you can imagine the amount of disinformation that's on social media, and so this ends up being a real issue. All right, so let's get a little more inspirational now and talk about some lessons from subspecialty health equity leaders and some of the things that we can do about some of these historical inequities. We, again, have a long history of good trouble health equity leaders in pediatrics, and I have to start out by giving a shout out to all general pediatricians who really have led this cause. And I want to give one example here. You guys familiar with this person? Dr. Mona Hanna Atisha. She's a pediatrician from Flint, Michigan, who was the one that noted that the lead levels in her patients were exceedingly high. And she was the whistleblower who then exposed high lead levels in Flint's water system to protect kids from having worse neurocognitive outcomes. So, she has really kind of been a major force in that area. That issue is still not resolved. They're working on it, but she was one of those good trouble instigators to help improve, again, be an advocate for the kids who didn't have their own voice. And I have to tell you, in my own field of pediatric cardiology, our entire field is founded on some of these DEI principles, including things like sponsorship, mentorship, allyship, and were it not for some of the good trouble that was caused in our own field, we would actually not exist as a field. And so I'd like to talk a little bit about that today. So this is Maud Abbott. She was the only woman in her medical school class in Canada. She was not allowed to practice internal medicine because she was a woman, okay? And she persisted and decided to work in pathology and took an interest in structural heart disease. And so she was invited to write a chapter in the book by a gentleman by the name of William Osler, I think everybody knows who that is, in the system of modern medicine, and created a new classification system for congenital heart disease. And he said it's the best thing he'd ever read, and really sponsored her to become essentially the grandmother of pediatric cardiology. This woman here, Helen Taussig, is a woman who tried to get into medical school and oftentimes was refused admission because she was a woman. And so from the donations of another woman who started a fund, Mary Elizabeth Garrett, she was at Hopkins, and she launched a national campaign to raise an endowment for the medical school. And she planned this for Johns Hopkins University, and she said, I have all of this money to give to you. And they said, that is awesome. Hand it over. And then she said, I will hand it over when you can assure me that half of the medical school class is going to be women. And because of her, Helen Taussig was admitted to the medical school at Hopkins, and she went on to be an amazing, essentially the mother of pediatric cardiology. She was nearly deaf and did all of her exams by palpation as a cardiologist. That is notable. And her advocacy was really noted because she was the first person who really advocated for blue babies to have surgeries. Prior to her, everyone thought it was a death sentence and no one would even touch them. And so she went on to be the first woman president of the American Heart Association and started the first pediatric cardiology fellowship program. So were it not for her, none of us would be here. Everyone is familiar, I think, with Vivian Thomas. He was an African-American man who could not afford to go to medical school in some states and was not allowed to go to medical school in other states because he was black. And he was a very skilled technician, lab technician, and was recruited to work alongside Dr. Alfred Blaylock in Tennessee. Dr. Blaylock is a cardiothoracic surgeon, and he was recruited to go to Hopkins. And he said, I will go if I can bring Vivian Thomas. And they said, no, you cannot bring him because he is black. And he said, I will not go unless I can bring him, and you have to make a provision. So he strongly advocated, caused him good trouble. They said, fine, bring him. And he started doing some experiments over there at Hopkins on dogs in labs to try to figure out how do you make a dog less blue if they are born, or how do you get more blood flow to the pulmonary arteries? And so because of him, they were able to create something called a BTT shunt, which is what all of us use every single day probably here. And it's what allowed for oxygenated blood to get to blue babies, and really what was the first step in allowing us to do surgeries. And so Dr. Taussig was the person at Hopkins, again, who convinced Dr. Blaylock to take a little girl who was 18 months old, who's had tetralogy Fallot, who was near death due to her TET spells. She convinced him to take her to the operating room. And that was great, except that Dr. Blaylock had done none of the surgeries on the dogs. That was Vivian Thomas. So he actually didn't know what he was doing. And so Vivian Thomas, he said, I need Vivian Thomas with me here in the operating room to be able to do these surgeries. And they said, well, he can't go to the operating room because he's black. We don't allow blacks in the operating room. And he said, you will let him into the operating room because I said so, and I'm the surgeon, and I said so. And so they listened to him. So that was, again, good trouble in our field that allowed for changing outcomes, right? And so this initial surgery ended up being a success. And you can see here, this is a true story, obviously, and that's Vivian Thomas. It's a true picture of Vivian Thomas standing behind Alfred Blaylock, telling him what to do during this first surgery, because Dr. Blaylock didn't really know what to do without his assistance. And so this entire story, by the way, is depicted in the film Something the Lord Made. If you haven't seen it, you should. It's a very inspirational film, but it is the true story of what happened here. Now, Alfred Blaylock was not perfect, okay, neither was Dr. Taussig, They did not give Vivian Thomas any publications or recognition of his work for all of the stuff that was published about the BTT shunt until decades later when he received an honorary degree from Hopkins. So he finally got his due, but it took a long time. So let's talk about some other health equity leaders in subspecialty fields. So this is Dr. Ray Bignali. He is an Assistant Chief Diversity and Health Equity Officer at Nationwide Children's Hospital in Ohio, and he is a leader in advocacy. He addresses social determinants of health in kidney health and transplantation through community-based interventions and leadership and engagement. And he is a member of the White House Equity Roundtable Series on Access to Care. He's a major force in health equity in a subspecialty space. What about this woman here? This is Dr. Rachel Levine. She is a 4-star admiral in the United States Public Health Service Commission Corps and served as the United States Assistant Secretary for Health since March of 2021. She is the first transgender official to ever serve on a federal organization and fights on behalf of preserving health equity for LGBTQ populations. And in fact, she also does a lot of work in environmental justice. So some of the things that we talked about that end up being the results of those red line areas, well, she proposed this new environmental justice index that would serve as a resource for communities, like the one that we showed you, for public health officials to identify and prioritize these overburdened communities to work together to find solutions. She does a lot of things. And again, she does adolescent medicine. Next is Dr. Kira Bona. She builds on DEI efforts in pediatric hematology oncology. She actually embeds social determinants of health interventions in existing randomized controlled trials in the pediatric cancer space, which is a very smart thing to do. And so what she did in her research was she said, okay, how does poverty impact outcomes in kids that have cancer, in particular neuroblastoma? And so she looked to see what the outcome of that was, and she said, what happens if we stratify outcomes based on poverty or not poverty? And she found that the outcomes were substantially worse if you had poverty versus not having poverty, even though you were treated in the exact same way in the exact same trial in the hospital. And so she found out that if you had neuroblastoma and you were poor, you were 2 times as likely to relapse and 3 times as likely to die, just based on that alone. Again, the treatments in the hospital were the same. So now she's putting interventions into these randomized controlled trials that directly impact social determinants to see what those outcomes can be and how they can be different. This is another health equity leader in the subspecialty space. This is a child psychiatrist. This is Dr. Joan Reed. She is one of the people who single-handedly changed my life. She was trained in child psychiatry and has created pipeline programs for high school students through fully trained physicians to increase underrepresented minorities in health sciences as well as in leadership and expertise of physicians in health policy spaces. So I learned all I know about health policy from Dr. Reed. And so I was fortunate enough to meet her in between finishing my chief year and starting my cardiology fellowship at Texas Children's. I was one of her Commonwealth Fund fellows in minority health policy. And her mentorship, sponsorship, leadership, and advocacy have shaped the lives of many, many health equity leaders in various fields, including adult medicine, surgery, pediatrics, dentistry. And along with my cardiology program director, Dr. Steve Nish, they helped me realize that even as a subspecialist, I too could play a major role in health equity work. So I'm very, very thankful for her. So Good Trouble during the COVID-19 pandemic also played a role in advocacy, engagement, and dissemination. And so despite the fact that I'm a pediatric cardiologist, as was mentioned this morning, I was somebody who was asked to be on the Mayor Turner's Health Equity Response Task Force. I was the only Latina and the only pediatrician on this task force. I want to remind you that Houston is 40% Latino. I was the only Latina on this task force, which is astounding. And so what we did was we put a lot of initiatives together to say, how are we going to get the messaging out to these various communities of color, not just Latinos, but Houston is actually the most diverse city in the nation. And so there's various Asian communities, African-American communities, et cetera, that are there. And so we had to think of how to tailor messaging to reach these different communities because it's not one size fits all. These messages are never one size fits all. And so we worked on these town halls that we did together on Univision, where we talked about what does it mean to have COVID-19, how do you do social distancing, et cetera. We talked about the vaccines and dispelling the myths of the vaccines. These were live Facebook forums, so people were asking questions, and we reached, and on average, we reached around 50,000 people with each telecast, which is great. I was then asked to give some really counsel or assistance to individuals in Brazil I think we all know that people there were also had challenges with understanding what was true and what was false in terms of the COVID-19 pandemic because of some of the disinformation that existed there, and was able to give town halls on behalf of the mayor to Latino populations in Spanish to talk about what are some of the things that can be done in these populations to reduce not only the transmission of COVID-19, but to talk about the safety of the vaccine. And so despite being a pediatric cardiologist, as someone who works in public health, this is an area that I was able to work in and was really thrilled to use my public health hat to be able to cause a little bit of good trouble to break up some of the myths that were existing in the communities. So let's talk a little bit about health equity research, okay, in this subspecialty space to impact pediatric chronic disease. And of course, as a pediatric cardiologist, most of what I'm talking about is going to be pediatric cardiology, full disclosure, but there's a few things in between there. So what are some of the things that we can do to increase health equity in the research space? Well, we can do collaborative partnerships to dispel some of the myths that exist in our subspecialty spaces or in pediatrics in general. So thanks to a collaborative partnership that I was able to work with the Texas State Health Department, we were able to work with the Birth Defects Registry to do a deeper dive into the arbitrary breakdown of race and ethnicity for various birth defects that existed. And so a lot of times the federal government actually arbitrarily made these categories to make it easier to do the census tracking. And so they broke it down to Hispanic, Black, white, Asian, and other, right? And sometimes Native American, depending on where you are. But it's clear that Latinos are not a monolith, and actually neither is any other population. And so we took a deeper dive into these birth defects and saw that really, if you were a Cuban American, you were doing just fine. There was not any issues for you at all in terms of outcomes. However, that was not true if you were Mexican American. If you're Mexican American, the outcomes were somewhat disparate. And so understanding that the myth of having everyone lumped together was not a reality, and it actually changes some of the outcomes, was really, really important for us to look into. Collaborative partnerships also allow for richer data in subspecialty pediatrics when you're looking at long-term outcomes, okay, because some of our populations and some of our diseases are quite rare. So this is a partnership that I was able to look at in the national level data with myself and a few amazing, brilliant pediatric cardiology colleagues, as well as this amazing epidemiologist. If you do not have epidemiologic friends or epidemiologist friends, I encourage you to find some. They are amazing to work with. And we were able to publish this in Circulation in 2020, looking at the National Death Index for Mortality, which of course is the worst possible outcome in congenital heart disease across the lifespan. And we found that while it was encouraging that overall the rates of mortality had decreased over that 17-year period from 1999 to 2017, race and ethnic disparities persisted. And so you can see there in the blue line, that represents African Americans. The black line represents white populations, and then the red line represents Latino populations. And you can see that throughout the entire period that black mortality was higher, substantially higher, and that there was a plateau in mortality for Latino infants, but there was no plateau in the white population there. And so, again, a lot of this has to do with some of those social determinants, upstream forces, et cetera, that we talked about. Collaborative research has the ability to move health policy in subspecialty pediatrics as well. And so when you question, why is this policy this way? So for example, why is it that when you turn 18, you fall off of Medicaid and your ability to get back on is impossible? Certainly in Texas, there is no safety net. There was no expansion of Medicaid. And so those patients really do have no more care after 18. And we have invested millions of dollars in them up front just to say good luck to you when they turn 18, which is not great. And so a lot of people said, well, actually, that's not true. We have the Affordable Care Act, and that should solve all of our problems. And so, and while the Affordable Care Act was great, it did not, in fact, solve all of our problems. And so this is some of the work that I did with a rock star cardiology fellow. She did this when she was a fellow, all the fellows in the room, Dr. Katie Salsiccioli, as well as Dr. Christopher Broda, as well as that same epidemiologist, Dr. Salemi, to look at the myth that the Affordable Care Act made access to care equitable for all patients, especially those who are chronic disease patients, using the National Inpatient Sample Database. And so you can see there on the x-axis is the pre-ACA levels, early ACA levels, and full ACA levels of those that are fully insured. And on the y-axis is the percentage of hospitalizations of those that are insured. And you can see once again that if you're Latino or Black, that your rates of insurance, whether you're in the transition space of 18 to 25 or 26 to 64, those are substantially lower than for a white population. So while the Affordable Care Act, as you can see, did increase insurance rates, and that's great, it has not solved all of this issue with inequity. So again, we talked about how in our field a lot of diseases tend to be rare. So multi-institutional collaborations also result in richer data for subspecialty pediatrics to look at health equity outcomes. So this is a study that we did looking at 21 Fetal Heart Society research collaborative institutions in the United States and Canada. We looked at over 1,800 fetuses with hypoplastic left heart and DTGA and evaluated whether socioeconomic status, public insurance, race and ethnicity, rural residence, et cetera, informed outcomes on prenatal detection of these diseases. And these are some of the most severe diseases we have in pediatric cardiology. So we found that a lower socioeconomic status was associated with lower prenatal diagnosis in hypoplastic left heart and DTGA at about 22% lower. We found that if you were Latino, you were 15% less likely to have a prenatal diagnosis of DTGA. Rural residents were 22% less likely to have a prenatal diagnosis of DTGA. And those with a lower socioeconomic status, rural residents, and public insurance were associated with a late prenatal diagnosis for both hypoplastic left heart and DTGA. And of course, that matters because sometimes late diagnosis ends up resulting in worse morbidity and mortality for these populations. We would never have been able to do this if we didn't collaborate together, all of these centers, and this is our own kind of collaboration, but this results in rich data that we can then say, this is what things look like, and this is how we can describe inequities in this space. How about understanding the role of social determinants of health? So how do we know how much the social determinants of health impacts some of these populations? And so this is a brilliant study done by one of my colleagues and friends, Dr. Shapavandi, looking at how the social determinants of health mediate outcomes in congenital heart disease populations. So she specifically looked at DTGA and hypoplastic left heart, and she looked to see in terms of a poor outcome, which she defined poor outcome as death before 1 year of age or readmissions before 1 year of age after you were discharged, to see what was the impact of maternal race on that poor outcome, as well as how did those social determinants mediate that outcome. So how do they play a role in that outcome? And while she found that maternal race, and she was specifically looking at Latino moms, maternal race played a role. 38% of this poor outcome was defined by the maternal race and or ethnicity. It turns out that the maternal education and insurance status played a much higher role, okay, at almost upwards of 60% on the impact on that poor outcome. So the social determinants played a larger role in the outcome, a much larger role in the outcome of poor outcomes that she defined than did maternal race and ethnicity. And so this is thing number 3 to take away from this talk, if you take anything away, is that race is a social construct. Okay, it is not inherently linked to worse clinical outcomes. So when we use race and ethnicity in our research, in our medical education, et cetera, we need to use it to represent social experiences and not biological facts. And we need to use it to explain the phenomenon that we see by providing a thorough interpretation of these results instead of just saying, hey, p-value is less than 0.01 for Latinos and blacks, thank you. We have to also then say, why is that? And take into account things like structural racism, social determinants of health, and implicit bias. We also need to move beyond descriptions of the problem because we've described the problem for a very long time. And so I often will ask, so now what? So we described the problem over and over, so now what are we going to do? And so we looked at, we've been trying to find ways to find interventions for the social determinants of health in areas of awareness, screening, research interventions, data dissemination, and how to assess that impact in some of our publications. This is for the Journal of Heart-Lung Transplantation in their heart failure populations to say, what can we do to improve outcomes? We also recently published a paper on applying interventions to address the social determinants of health and reduce health disparities, specifically looking at interventions that have worked in other fields and other medical fields and saying, how can we apply that to pediatric cardiology to improve some of these outcomes? If you haven't read this, I would encourage you to do so. This is, I had the pleasure of chairing the scientific statement for the American Heart Association on addressing social determinants of health and mitigating health disparities across the lifespan. And in it, we talk about how do you make an impact at the individual level, at the population level, from short-term solutions to long-term solutions. And we go over a variety of different areas. And so I would encourage you to look at that if you haven't already. All right, so how do you translate your voice into health policies that reduce pediatric health inequities? So I have to talk a little bit about representation just for a moment. And these are words from a mom, Tawana Nishibayashi, who gave a presentation at the Cardiac Networks United presentation in 2020 about her experience as a black mom of a black child in a cardiac ICU. Her child has had at least 5 open heart surgeries. And this is what she had to say about why representation is important. The onus is on me to actively dispel stereotypes daily in one of the most stressful and traumatic experiences that one can go through repeatedly, every hospital stay, every fellow attending a medical staff that I encounter. Racism happens in hospital settings as in life every day. Seeing someone that you and your child can relate to help make you feel included. Representation is important, and it matters to see someone who looks like you for a variety of reasons to inspire comfort and understanding, and maybe you don't have to fight quite as hard. And it turns out that there are several studies that demonstrate that who one's medical provider is can change patient outcomes if you're from a community of color or for those for whom English is not your first language. Not being able to adequately communicate or ask questions to your provider because of a language barrier, or not having your symptoms taken seriously because you're a woman or because you're from a community of color, really can change your outcomes and can impact outcomes. And finally, not feeling comfortable speaking about certain issues because you're from a marginalized and historically disenfranchised population, such as those from the LGBTQ community, can certainly impact how you interact with the medical system. So we are trying in cardiology to see how some of these things impact outcomes in our population. So this is a publication just hot off the press, you can see November 2022 here, from Canada, looking at how structural racism, social determinants of health, and provider bias impact the brain development in those with critical congenital heart disease. So we're talking beyond antegrade cerebral perfusion. We're talking beyond having blue blood or purple blood, your brain seeing purple blood. These are things that are additional to those things that we already know cause neurodevelopmental defects or issues. So what can we do in our institutional policies to make really a mark on reducing health inequities? We can diversify subspecialty leadership and the mission of the institution. We can improve underrepresented minority recruitment for fellows, faculty, and residents, and not just recruitment. Retention is just as important as recruitment. We can do implicit bias training, microaggression training, race training, I'll talk about it in just a moment, and health and digital literacy recognition. It is imperative that we understand what our patients understand about the care that we're delivering. Ensuring appropriate language and parent services and supports, community partnerships in the design and delivery research. So what we think is important for communities, they might think that's not important at all, and unless we ask them, we won't know. And then, of course, social determinants of health screening. At this stage, knowing all that we know, it is critical that we start doing screening in all areas of clinical research, including the ICU, outpatient clinics, et cetera, as well as in areas of research. If you haven't seen this, this is a series of publications on race and medicine in the New England Journal. It has tons of articles. It's free to access, and it's really an impressive amount of articles that they have. This is one example here. Misrepresenting race, the role of medical schools in propagating physician bias. That's just one example, but I would highly encourage you to look at this set of articles. And again, it talks about what we call race training. In other words, what is the appropriate use of race in research, in education, et cetera. At the systems level, we need to use advocacy, and in fact, social media can amplify healthcare bills and at the state and local level, and diversifying journal editors and academic societies. Once again, social media can help with that. So why are certain things published versus not published? Why is that? Why are certain topics discussed at some of our national meetings versus others? Who's speaking? Who makes the decisions? Funding mechanisms to improve lifelong care. So loan forgiveness for increasing the workforce for ACHD, and transition and transfer programmatics, which we typically have no funding for. Improving the role of fellowship funding slots for and URM training. I don't know if you guys know this, but fellowship slots, especially fourth-year slots, are often not covered by Medicaid, which are the things that cover residency programs. And then improving data transparency for morbidity and mortality, especially for patients who have a hard time with health literacy. Finally, at the state and local level, accessing chronic disease care across state lines. So if you're living in Indiana, and you live in Gary, Indiana, it's about a half-an-hour drive to Chicago, but you have to go to Riley Children's to get your care, which is about 3.5 hours away, which is ridiculous. And so because Medicaid funds at lower rates across state lines, those are things that impact access to care. Understanding that Medicaid expansion is critical for helping patients with chronic disease and advocating for that, and modernizing how to stay on public insurance. I don't know if you guys know, but staying on Medicaid is really hard. You have to kind of reapply frequently and often, and again, if you have to do that online, it's really hard. And finally, at the federal level, protection for kids with pre-existing conditions like the Affordable Care Act, making sure that that stays in place. Improving access and affordability of mental health services, that's a big deal right now. Reimbursement for shared and unique delivery care models. Again, we don't have enough doctors to take care of our aging CHD populations. And increasing research funding for social determinants of health and health equity interventions. Funding research programs also focus on reducing health disparities is going to be critically important moving forward. If you haven't seen this, every single subspecialty should have a policy statement like this. This is our policy statement that was published in JAHA about healthcare policy and what we should focus on in congenital heart disease in our future. And it has a variety of different areas that we think we should focus on various different sectors. So really, if you see inequities, you should question them, you should say something, you should do something, you should research, advocate, and lead to change outcomes. Your subspecialty voice should be used for good trouble. And with that, I'd just like to give a shout out to National Native American Heritage Month, which is this month in November, and I'm happy to take any questions.
Thank you so much, Dr. Lopez, for this tour de force and a truly inspiring talk. I learned so much, and I'm sure that's true for everybody here. The floor is open for questions for this talk. While people are organizing their thoughts,
Either that or they're terrified. I'm not sure.
Well, it's just so much to take in and go back to. But I was wondering, as somebody who kind of lives and breathes this, throughout your career and research, et cetera, but also as a clinical cardiologist, how do you incorporate what you know about the background when you see a patient in front of you into your practice? How do you try to be conscious while you treat a patient with congenital heart disease and their family of these factors that some of which may be applicable to them?
Well, I think it's really important to listen. A lot of times we're really good at talking, we're really bad at listening to hear what patients have to say in terms of the needs that they have. But the other thing is, you don't know what you don't know. And so unless we screen them for their social determinants or for their health literacy, in the clinical space, we really don't know where they're at. So we try to make assumptions about where we think they might be at or what we think is important, et cetera. But unless we actually reach out to them and say, okay, what are the needs that you have? Oh, you can't buy, we will label them as someone who's non-compliant with an Allopril, for example, and then realize, oh, it was either buying an Allopril or buying food for the home. Well, it was one of the two. And so things like that really change either our perceptions of the care that they need or the care that they're actually getting or receiving, because a lot of times what we think is feasible, possible, may not be. Someone who's late to clinic, they might have one car for someone who's now coming off a night shift that needs to then drive and dropping off other kids at school. And this all needs to happen seamlessly because it's on our time, on our schedule.
And how do you screen them? Is that a conversation? Is that a more systematic process? How do you go about that? Do you do that?
So that's an excellent question. I think that it is unrealistic to expect cardiologists to do this. Or speaking about cardiology, I can't do everybody else, but I think it's unrealistic to ask us to, in addition to doing all the other things in clinic, to be like, can you also screen for the social determinants? That's not realistic. So it has to be built into the system. It is an institutional system-based priority that has to happen. And the screening either has to happen at the intake, when they're kind of at the front desk, or at some other level to then flag them. And then that flag should then generate another set of forces that then come in. I'll be talking a little bit about some of the interventions that we've done for food insecurity this afternoon. But that is, it is critical that we institute it at the institutional level. It has to be a priority that's funded, that allows for forces that then assist in ways that they can to get the patients what they need beyond the standard doctor-patient relationship.
Thank you. Mark.
Thank you. It's a very provocative lecture. Sorry for my speech. Could you? It seems your presumption is, and it may well be correct, but there are no racial differences per se that cause any healthcare differences. Are they all social determinants, or are there in fact some racial differences in health that are important?
You mean genetically?
Yes.
Biologically? If that's true, it's true at the smallest possible level, because the DNA is so similar between the various populations that if it's true, it's small. It's true at a very minute level. Now, of course, if you have something like an inborn error of metabolism, or something that's obvious, right? Or if you have like Turner's or something, that's clear. But otherwise, the difference in our genetics is so minimal that it is far more likely that the outcomes that we're seeing have far, far more to do with the social determinants than any biologic factors. And it's interesting, this afternoon I'll be talking about how that came to light in the COVID-19 pandemic and the things that differentiated us from Europe and Asia that really made it clear that it was not biologic.
Okay, we're going to have time for one more question, unfortunately, because we're at time. I think, Kathy, you had a question? Or okay.
I've been thinking a lot about not only medical education, but professional education in our workplace and our workforce. And how we retrain ourselves to think outside the box, as you're discussing. Can you, at this point, based on your experience, distill that into, and maybe you've distilled it into making good trouble, the point of actually asking out loud, whether it's in our workplace, but can you distill that into some particular nuggets that are extremely important for our everyday workplace with not so much our patients, but with each other, as we uncover some of these systemic biases that may be within our own institutions?
Thank you for that question. I'm assuming people heard it because you used the mic. So I will tell you that one of the least appreciated at the kind of between ourselves in the workplace, one of the least appreciated areas is microaggressions. And so people talk a lot about implicit bias, but microaggressions are arguably more important than that in understanding the various different microaggressions that exist and how those play out between each other. Because we all have assumptions about the other subspecialty, right? And so understanding how that works, and I'll be talking about a little bit about that this afternoon as well, understanding what that looks like and how that works is important. The other thing that I'd say is listening. I know that sounds ridiculous, but listening to what the other person has to say, we're very, very good at talking. We're very, very bad at listening. So understanding what the perspective is of the other person and why that is in our own spaces is also important. And I think cultural humility is one other thing. So we talk a lot about cultural competence. I think that cultural competence is a thing of the past, and that cultural humility is what we need to be working towards, because that says you are the expert of your own space, of your own experience, and I am someone who can learn from you, not, oh, I learned a fact about your where you live or neighborhood you're from, check, like on some box for cultural competence. So I think the combination of those things, even within our workplace, those small things, I think can make a big difference.
All right, I think we could continue this conversation for much, much longer. I apologize to everybody in the chat because there's more questions in there. What we'll do is we'll copy those questions and we'll work with Dr. Lopez to get you those answers. I am humbled by all the things that that we still need to do and that I don't know, but I'm tremendously optimistic and encouraged by all the work that you and others are doing in this field. Thank you very much for coming this morning, Theo Casson and Grand Art speaker. I encourage everybody to join us for our afternoon lecture, which is going to be a lot about DEI again and quality improvement work, and we'll get more questions answered at that time. Thank you very much.
Thank you.